Welcome back to the deep end. Today we are shifting gears. We're not just exploring a topic, we are stepping into a simulation. I want you to close your eyes for a second. Imagine the hum of the air conditioner, the smell of sterile drapes, the rhythmic beeping of the monitor, and then suddenly imagine that rhythm stops.
The terrifying silence of a pulse oximeter that has nothing to detect.
Exactly. Or, perhaps more relevant to where your head is at right now, imagine the silence of an exam hall in Gujarat. You have a blank sheet of paper, the clock is ticking, and a 20-mark question is staring back at you. Discuss the pathophysiology, clinical features, and emergency management of anaphylaxis.
It is this scenario that wakes every anesthetist up in a cold sweat. In the operating theater, we call it a table death scenario. It's chaotic, it is fast, and it is absolutely unforgiving. But in the context of the MD anesthesiology exam, specifically for Gujarat University, this isn't just a nightmare. It is a guaranteed topic. You are going to see this.
In some form or another.
Absolutely. It might be a long case where a patient has a history of an undefined allergy. It might be a short note or, very commonly, it's that high-stakes Viva station where the examiner points to a mannequin and says, the blood pressure is unrecordable. Save the patient.
So today, my co-host isn't just an expert. I want you to think of them as your senior MD anesthesia faculty. They are the mentor standing over your shoulder, guiding you through the theory so you can recall it when the pressure is on.
That is exactly the role I want to play today. Because when you're dealing with anaphylaxis, you don't have time to look up a textbook. You don't have time to, Google the dose of adrenaline. The protocol needs to be a reflex. It needs to be muscle memory.
Our mission is clear then. We're going to provide a comprehensive protocol-based audio overview. We're taking the stacks of Harrison's, Miller's, and Morgan and McLeod's and distilling them into something you can carry into the exam hall and the OT. So let's start at the beginning. If you get that 20-mark question, how do you open your answer to show the examiner you mean business?
You start with a precise definition. You need to anchor your answer immediately. According to the standard texts, Harrison's, Miller's anaphylaxis is defined as a life-threatening systemic hypersensitivity reaction. It's rapid in onset, and it can be fatal.
Get those keywords in right away.
Exactly. And immediately after that definition, you have to address the elephant in the room, the distinction between anaphylaxis and anaphylactoid reactions.
Right. I see this pop up all the time in the literature. What is the difference? And I guess more importantly, does it matter when the patient is crashing?
Well, that's the key. Physiologically, it matters immensely. Clinically, in the moment, it does not. And that is the exam phrase you need to write down. Anaphylaxis is strictly an IgE-mediated reaction. This means the patient has been exposed to an antigen before, their body has created specific IgE antibodies, and those antibodies are primed and waiting on mast cells. It requires prior sensitization.
So they've been primed.
Yes. Anaphylactoid reactions, on the other hand, are non-IgE-mediated. The offending agent like, say, morphine, vancomycin, or certain contrast media, it bypasses the antibodies entirely and directly stimulates the mast cell to explode and release histamine.
So one is a specific key opening a lock, and the other is just kicking the door down.
That's a perfect analogy. And here's the expert note for your Viva. Clinically, they look identical, they present with the same hypotension, the same bronchospasm, and crucially, they are treated identically. You treat the reaction, not the mechanism.
Okay.
Now, just as a side note, the World Allergy Organization, or WAO, has actually recommended dropping the term anaphylactoid. They prefer non-immune anaphylaxis to simplify things.
That does make more sense.
It does. But in an exam setting, you need to know your examiner. If they're old school, sticking to the traditional distinction of anaphylaxis versus anaphylactoid, it shows you understand the underlying mechanism.
Why is this such a critical topic specifically for anesthesia? I mean, allergies happen everywhere. People get stung by bees, people eat peanuts.
Because in anesthesia, we work in the dark. The signs are masked.
The patient can't talk to you.
Exactly. If you eat a peanut and have a reaction, you can tell me your throat feels tight or you feel a sense of impending doom. An anesthetized patient cannot complain. They cannot scratch an itch. They can't tell you they can't breathe. The first sign we often see is cardiovascular collapse. That is why the mortality rate is so much higher in the perioperative setting. We lose the early warning system of the conscious patient.
And in terms of the exam pattern, how does this usually manifest itself?
For a long answer question, a 20 marker, they will demand the pathophysiology, a detailed clinical picture, and most importantly, a management flowchart. If you get this in a Viva or an OSCE, it is going to be rapid fire. They will ask for the immediate drug of choice,
Adrenaline.
and they will grill you on the differential diagnosis of hypotension. You need to be ready to pivot between the science and the practical management instantly.
Okay, let's move to the second section of our outline. Etiology and triggers. This is flagged as very high yield. If we're in the OT, who are the usual suspects?
We call them the big three in anesthesia, based on Miller and Morgan. Number one, by a significant margin, are neuromuscular blocking agents, or NMBAs.
The muscle relaxant.
Yes, the muscle relaxants. Studies suggest they account for anywhere between, let's say, 58 to 70% of perioperative anaphylaxis cases. The main culprits are usually succinylcholine and rocuronium.
And why them specifically?
It's because of the quaternary ammonium ions in their chemical structure. They are highly antigenic. They're just the right shape to trigger this kind of reaction.
I recall reading something in the notes about cough syrups. The Fulcadine hypothesis. This sounds like a story.
Yes, this is a fascinating little nugget for the distinction student. Fulcadine is an antitussive, a cough suppressant, that's used in some countries. It essentially sensitizes the population to these quaternary ammonium ions.
So someone takes cough medicine for a cold.
Exactly. A patient might have never had surgery, never seen rocuronium, but they took a cough syrup 3 years ago. Their body built antibodies to the ammonium ion in the syrup. Now, you induce them for surgery, you give rocuronium, and bang, massive anaphylaxis.
Wow.
It's a cross-sensitivity issue. It explains why we sometimes see reactions in, virgin abdomens, people who've never had surgery before.
That is incredible. It really highlights how interconnected these chemical structures are. So NMBAs are number one. Who's number two?
Historically, it was latex. That's becoming less of an issue as we move to latex-free environments. But for the exam, it is still a major concern.
And you need to know the high-risk groups.
You do. Children with spina bifida because of repeated catheterizations, healthcare workers from chronic exposure, and patients with multiple prior surgeries, like urological procedures.
And number three?
Antibiotics, specifically penicillins and cephalosporins. This is where you get asked about cross-reactivity.
Right, the 10% rule.
The old teaching was that there's a 10% cross-reactivity between penicillin and cephalosporins. Newer data suggests it's much lower, maybe 1 to 2%, and it's really dependent on the side chains of the molecules. But if a patient has a history of anaphylaxis to penicillin, not just a rash but true anaphylaxis, you generally avoid cephalosporins to be safe. It's the safest answer for the exam.
Are there any other triggers that might sneak up on us in the OT?
Absolutely. Colloids are a classic cause. Dextrins and gelatins have a high potential for histamine release. Then there is chlorhexidine.
The cleaning solution.
Exactly. This is an emerging and often overlooked culprit. It's on the central lines. It's in the urethral gels. If a patient reacts and you can't blame the drugs, look at the antiseptic. And rarely blood products, specifically in patients with IgA deficiency who receive blood-containing IgA.
When does this usually happen? Is there a specific time on the clock we should be most worried about?
The danger zone is induction. About 90% of reactions occur shortly after induction.
That makes sense.
It does. Think about it. That is when you are pushing the antibiotics, the muscle relaxant, the induction agents. All the high-risk antigens are entering the circulation at the same time. It's a chemical storm.
Which makes the diagnosis even harder because hemodynamics change during induction anyway. What about risk factors? Does having asthma make you more likely to have anaphylaxis?
This is a common misconception and a favorite trap in the Viva. Atypiso, a history of hay fever, asthma, eczema, does not necessarily increase the risk of becoming sensitized to specific anesthetic drugs.
So an asthmatic isn't more likely to be allergic to rocuronium?
No, not more than anyone else. However, and this is the key, if an atopic patient does have a reaction, their ability to compensate is worse. The bronchospasm will be much more severe. So atopia increases the severity of the reaction, but not the incidence of the drug allergy itself.
That's a very important distinction.
It is. Also, statistically, female gender is a risk factor, likely due to hormonal influences on the immune response.
Let's get into the mechanics of the bomb going off. Section 3, Pathophysiology. This is exam core. Walk us through what is happening at the cellular level.
You need to visualize the mast cell. In a type I hypersensitivity reaction, the IgE-mediated kind, the patient has previously been exposed to an antigen. Their immune system created specific IgE antibodies. These antibodies then attach themselves to the surface of mast cells and basophils, specifically to a high-affinity receptor called Fc epsilon Ri.
So the mast cell is loaded. It's a mine waiting for a ship.
It is primed. Exactly. Now, upon re-exposure, the antigen enters the bloodstream. It finds and binds to those IgE antibodies. But here's the key mechanism.
The cross-linking.
The cross-linking. The antigen must bridge or cross-link two IgE molecules together. This sends a signal into the cell, which causes a massive influx of calcium.
And calcium causes the explosion.
Correct. It triggers degranulation. The mast cell literally releases its chemical soup. And we divide these mediators into preformed and newly synthesized. The preformed ones are released immediately. The big player here is histamine. It causes vasodilation and leakiness. You also get tryptase, which is our diagnostic marker, and heparin.
And the newly synthesized ones, they come later.
They take a few minutes to form. These are the lipid mediators, leukotrienes, and prostaglandins. For the exam, you must remember leukotrienes C4 and D4. They are incredibly potent bronchoconstrictors. Some texts say 1,000 times more potent than histamine.
Wow.
They are what sustain the reaction.
So histamine knocks them down and leukotrienes keep them down.
Precisely. And functionally, this leads to systemic chaos. In the cardiovascular system, you get massive vasodilation from nitric oxide release. Capillary permeability increases so much that you can lose up to 35% of your intravascular volume into the extravascular space within minutes.
So it's a distributive shock and a hypovolemic shock at the same time.
A perfect way to describe it. And in the respiratory system, you get laryngeal edema and that intense bronchospasm.
This transitions us perfectly to clinical features. As you mentioned, the patient is under general anesthesia. They can't tell us their throat hurts. What are we seeing on the monitors and on the patient?
The presentation is masked. The most common sign in the operating theater is cardiovascular collapse. We are talking profound refractory hypotension.
What do you mean by refractory?
It means you give a little ephedrine, nothing happens. You push fluids, nothing happens. It just doesn't respond to your usual measures. It might present as tachycardia initially or arrhythmias and can rapidly progress to cardiac arrest.
And on the respiratory side, what does bronchospasm look like on a ventilator?
It shows up as increased peak inspiratory pressure, or PIP. The ventilator alarm starts screaming, high pressure. On the capnograph, you'll see the upstroke of the waveform start to slur, the classic shark fin appearance of expiratory obstruction. And if cardiac output fails completely, your end-tidal CO2 will suddenly drop to near zero.
Because there's no blood flow to the lungs to deliver the CO2.
Exactly. No perfusion.
What about the skin? We always associate allergies with rashes and hives.
Cutaneous signs, flushing, urticaria, angioedema, they are classic. But here's the warning. They may be absent initially.
Why is that?
If the patient is profoundly hypotensive, there is no skin perfusion. You cannot have a red, angry rash if there is no blood in the skin. Often, the rash only appears after you have started resuscitation and restored some blood flow. So do not rule out anaphylaxis just because the patient isn't red. That's a critical point.
For exam thoroughness, should we mention any grading scales?
Yes, briefly mentioning the Ring and Messmer grading scale is a nice touch. It shows you've read around the topic. It goes from grade 1, which is just skin signs, all the way up to grade 4, which is cardiac arrest.
Okay, so you're in the OT, the blood pressure plummets, the airway pressures are sky high. It could be anaphylaxis, but it could be other things too. Let's talk differential diagnosis.
Right, this is the crisis checklist. If you have hypotension, you have to mentally rule out an overdose of induction agent. Did you just push too much propofol?
Or high spinal.
High spinal block causing sympathectomy, yes. Is there massive hemorrhage we haven't noticed? Sepsis? Or is it a tension pneumothorax?
Tension pneumothorax is a big one because it also causes high airway pressures and hypotension.
Exactly. And then for the bronchospasm side, you have to ask, is the anesthesia just too light? Is the patient bucking on the tube? Is the tube in the right main bronchus?
Endobronchial intubation?
Yes. Or did they aspirate? Is it pulmonary edema?
How do you differentiate clinically in that split second when everything is happening at once?
Anaphylaxis often, though not always, combines the two. Profound hypotension plus severe bronchospasm, often with cutaneous signs appearing later. A pulmonary embolism might drop your EtCO2 and your blood pressure, but it rarely causes the sky-high airway pressures of a true bronchospasm. A tension pneumothorax will have unilateral, absent breath sounds. But here's the bottom line. In the heat of the moment, if you cannot rule it out, you must treat for anaphylaxis. The treatment for anaphylaxis adrenaline won't necessarily hurt a light plane of anesthesia, but missing anaphylaxis is fatal.
That brings us to diagnosis. You said clinical is king.
Absolutely. And you must state this in your answer. Treatment must never wait for a lab test. Diagnosis in the acute phase is presumptive and clinical. However, for the exam and for retrospective confirmation, we use serum tryptase.
Tell us about the timing of the sample. This feels like a classic Viva question.
It is. Tryptase has a half-life of about 2 hours. So you need to take the first sample within 1 to 2 hours of the reaction. That's to catch the peak. Then you need a second sample about 24 hours later to establish the patient's baseline.
Why the baseline?
Because some people have a naturally high tryptase level, a condition called mastocytosis. You need to prove that the level spiked and then came down. A significant rise confirms mast cell degranulation.
But does it prove it was true anaphylaxis?
Another great Viva point. No. Tryptase does not distinguish between IgE-mediated or anaphylactic and non-IgE-mediated or anaphylactoid mechanisms. It just tells you the mast cells exploded.
What about skin prick testing?
That is for much later. You do skin prick testing, SPT, or specific IgE testing, which is a blood test, 4 to 6 weeks after the event. You can't do it immediately because the mast cells are depleted. They've dumped all their granules. You will just get a false negative.
All right, this is the most critical part of our deep dive, Section 7. Immediate management. The patient is crashing. What do we do step by step?
Okay. Step 1. Stop the antigen. If you are running an antibiotic infusion, clamp it. If you are injecting Rocuronium, stop pushing the syringe. Step 2. Call for help, loudly. You cannot manage this alone. You need extra hands. Step 3. Airway and oxygen. Get them on 100% oxygen.
And what about the volatile anesthetics? Do we turn them off?
This is a bit debated. Volatiles are vasodilators, which is bad for hypotension, but they're also bronchodilators, which is good. However, most guidelines say wash them out. The priority is ensuring 100% oxygen delivery and removing any potential contribution to the low blood pressure. So yes, turn them off.
No, the drug of choice.
Adrenaline. If you remember nothing else from this session, remember this. It is non-negotiable.
Why is it the magic bullet? What does it do?
It does everything we need it to do. It has alpha-1 activity, which reverses the vasodilation and fixes the hypotension. It has beta-1 activity to support the heart anotropy and chronotropy. And crucially, it has beta-2 activity.
Which does two things, right?
Right. It bronchodilates the lungs, and it stabilizes the mast cell membrane to stop further degranulation. It actually stops the process.
Let's talk dosing. This is where students fail. What is the dose?
You must be absolutely precise here. Do not say 1 milligram casually. If the patient have a pulse, let's say it's grade 2 or 3 anaphylaxis with hypotension, you give small, titrated boluses. The dose is 10 to 50 micrograms Phe.
Micrograms, not milligrams.
Micrograms. If you slam 1 milligram into a patient who still has a pulse, you will cause ventricular tachycardia and a hypertensive crisis. Do titrate it. 50 mcg, check the response. 50 mcg, check again.
But if they're in cardiac arrest, no pulse.
If there is no pulse grade the 5, then you switch to the standard ACLS protocol. That is when you give the 1 milligram IV bolus and you repeat it every 3 to 5 minutes.
And if the small boluses aren't holding the pressure up?
You start an infusion. The textbook range is 0.05 to 1 microgram per kilogram per minute, but practically you titrate it to effect. You turn it up until the blood pressure is stable.
Okay, moving to airway and breathing. We've given oxygen. What if the airway is swelling up?
You intubate early. Angioedema can progress to complete obstruction in minutes. If you even suspect airway swelling, secure the tube now before it's too late.
And for the bronchospasm?
In addition to the adrenaline, which is the best bronchodilator, you can give salbutamol puffs down the endotracheal tube. You can use IV ketamine. It's a fantastic bronchodilator.
Yeah.
And as we said, you could even use volatile agents if the blood pressure allows.
And circulation. We have given adrenaline. Do they need fluids?
They need massive amounts of fluid. Remember, they have lost up to 35% of their volume into the tissues. It's a capillary leak syndrome. You need to fill the tank.
How much are we talking?
We're talking 20 to 40 milliliters per kilogram of crystalloids, given very quickly. Do not be shy with the fluids.
What if adrenaline and fluids aren't working? What if the hypotension is truly refractory?
Then you need to think about second-line vasopressors. Vasopressin is excellent for refractory vasodilation. A bolus of about 2 units, IV, can work wonders. And here is a specific exam scenario. If the patient is on beta blockers, adrenaline might not work well because the beta receptors are blocked.
So what's the answer?
The answer is glucagon. Glucagon bypasses the beta receptor to increase cardiac contractility and heart rate. That's a high-level point.
Let's touch on adjunctive therapy. Antihistamines and steroids. We always hear about them.
And in the exam, students always mention them too early. These are too little too late for the acute resuscitation. They are secondary.
So what's their role?
Antihistamines, like diphenhydramine, an H1 blocker, and ranitidine, an H2 blocker, are great for the rash and the itching. They do not save lives in shock. Corticosteroids, like hydrocortisone, maybe 100 to 200 milligrams, take 46 hours to work. Their mechanism is gene transcription. We give them to dampen the late-phase reaction and prevent a recurrence, not to fix the blood pressure right now.
So the mantra is adrenaline, then fluids.
Adrenaline first, fluid second, everything else is adjunctive.
Section 9 focuses on management in the operating room. We have stabilized the patient. The surgeon is standing there with a scalpel. Do we proceed or abort the surgery?
This is a classic exam favorite decision-making question. If it is elective surgery, a hernia repair, a cosmetic case, you abort. The patient has just survived a near-death event. Their entire physiology is deranged. Stop the surgery, transfer to ICU.
And if it's an emergency?
If it's a dire emergency, a C-section for fetal distress, a ruptured aortic aneurysm, an extradural hematoma, you have to weigh the risk. Generally, you stabilize the hemodynamics as best you can and proceed with extreme caution, often switching to an anesthetic technique that avoids the likely trigger if possible.
And documentation during all of this.
It is absolutely crucial. You must document the timing of the event, the drugs given immediately prior, every vital sign and every dose of adrenaline and the response. You must inform the surgeon immediately and later the family.
What happens after the OT post-anaphylaxis care?
ICU admission is mandatory. You cannot send this patient to the ward. The reason is the risk of a biphasic reaction.
What is that exactly?
In up to 20% of cases, the symptoms can recur 4 to 8 hours later, even with no new exposure to the antigen. It is like a second wave of mediator release.
And that's why you give the steroids.
That's why we give steroids and why we monitor them in a high-dependency setting for at least 24 hours. Post-discharge, the patient needs counseling. They need to understand they had a life-threatening reaction. And they must have a referral to an allergy clinic for that skin testing we mentioned to identify the culprit so future anesthesia is safe.
Let's talk prevention and risk reduction. Is there any way to predict this?
History taking is your most important screening tool, but you have to ask the right questions. Don't just ask, are you allergic to anything?
Be more specific.
Be very specific. Ask about previous issues at the dentist or swelling of lips after blowing up balloons. That points to latex. Ask about tropical fruit syndrome. An allergy to bananas, kiwis, avocados often cross-reacts with latex.
And if they say they are allergic to penicillin,
then you practice avoidance. If the documented reaction was anaphylaxis, you avoid cephalosporins too, just to be safe for the exam. If it was just a mild rash, a cephalosporin might be okay, but in an exam setting, safe anesthesia is the right anesthesia.
what about pre-medication with steroids and antihistamines?
It is standard practice for things like radiocontrast media allergy. But for preventing true IgE anaphylaxis to anesthetic drugs, the evidence is quite weak. It might mask the early skin signs, but it won't stop the cardiovascular collapse.
We are nearing the end. Let's do a roundup of common exam questions and Viva traps. Where do students usually slip up?
Trap number 1, the adrenaline delay. Students so often list management as stop drug, give oxygen, give steroids, give antihistamine, oh, and adrenaline. That is an immediate fail.
Adrenaline is first.
Adrenaline is first, second, and third. It's the most important drug. Trap number 2, the wrong dose. I will say it again. Giving 1 milligram IV to a patient with a pulse is dangerous. You must specify titrated boluses of 50 micrograms. Precision matters. Trap number 3, the beta blocker patient. The examiner will ask, you gave adrenaline, but the heart rate isn't coming up. Why? You must be able to identify beta blockade and suggest glucagon.
And for the visual learners, how should they present this in a written paper to get top marks?
Visualizing the answer scores very high marks. First, draw the mast cell. It takes 30 seconds. Show the IgE antibodies, the antigen cross-linking them, and the calcium influx leading to degranulation. It explains the entire pathophysiology perfectly.
And a flowchart for management?
Absolutely. A simple flowchart, trigger recognition, adrenaline, about fluids, task secondary drugs. It structures your thinking. And when you're writing the long answer, spend maybe 20% on the definition and pathophysiology, but spend 50% of your time and space on management. The examiner wants to know you can save the patient.
Before we wrap up, let's summarize. A rapid-fire recap.
Okay. 1, anaphylaxis is IgE mediated. Anaphylactoid is non-IgE, but clinical management is identical. 2, common triggers in anesthesia are NMDAs, especially acetylcholine and rocuronium, followed by antibiotics and latex. 3, the clinical diagnosis is based on hypotension and bronchospasm. Remember that skin signs may be absent initially. 4, lab diagnosis is confirmed retrospectively by serum tryptase with a 1-hour and a 24-hour sample. 5, immediate treatment is stop the trigger, adrenaline, fluids, and oxygen, in that order of priority.
And for the student who wants that extra point, the provocative thought to leave the examiner thinking.
you should mention Sugammadex. If the anaphylaxis is caused by Rocuronium, there is emerging evidence and a strong theoretical benefit that giving a high dose of Sugammadex 16 milligrams per kg might actually encapsulate the Rocuronium antigen and help terminate the reaction.
So it removes the trigger from the system.
Exactly. It's cutting edge, not yet in every single guideline, but it shows you're reading the latest journals and thinking ahead.
That is exactly the kind of insight that turns a pass into a distinction. We have unpacked the pathophysiology, the protocols, and the pitfalls.
And remember, in the exam, as in real life, safe anesthesia is the right anesthesia. Recognize early, treat hard with adrenaline, and never, ever hesitate to call for help.
Good luck with your preparation. You have got this. We will see you on the next deep dive.
Steady hard.